I thank the AML Hub for inviting me to discuss on personalizing care with FLT3 inhibitor therapy. And also I thank the support for preparing slides. These are my disclosures. As you all know, approximately 1/3 of patients with AML have FLT3 ITD or TKD mutations, and also patients with acute promyelocytic leukemia have these types of mutations in 30 to 40% of cases. It is already known that these mutations are not initial events, but evolutive genetic abnormalities. And both types, ITD and TKD, lead to constitutive activation and downstream signaling in different pathways, such as PI3K, AKT, JAK-STAT, RAS-RAF, and others. And FLT3 mutations led to this proliferation and are usually associated with high blood cell counts and high relapse rate. As you may see in the figure, ITD mutations involve the juxtamembrane in most cases of the receptors, and in a minority, the beginning of the TKD. The FLT3 ITD are observed in 20 to 25% of patients with AML, and TKD mutations in 7 to 10%. We have two main techniques to identify FLT3 mutations. The more commonly used is the fluorescence labeled PCR with a sensitivity of 5% and very rapid turnaround time. And more and more recently is being introduced NGS also to test the presence of these mutations, and very importantly, to follow the minimal residual disease. Also, it's important that patients with AML in relapse are tested for FLT3 mutations, because patients with these mutations at diagnosis may become negative at relapse, may change from ITD to TKD, or if they are negative at diagnosis, they may become positive at relapse due to the growth of a microclone. In FLT3 mutated AML are very frequent commutation, and of them, the most common, as you may see, are MPN1 and DNMT3A. Classically, the coexistence of these three mutations was considered an adverse prognostic factors, but with the introduction of quizartinib and also with midostaurin, this triple combination has lost the adverse impact. Regarding the prognosis, both in the ELN22 classification for fit patients, as well as in the ELN24 classifications for patients receiving less intensive therapies, FLT3 ITD is considered intermediate risk, and FLT3 TKD is not considered in the genetic risk classification. Patients with FLT3 ITD who are in remission are candidates for allogeneic transplantation whenever possible, and as we will see, depending on the persistence of minimal residual disease before or after transplant, also to continuation after transplant with FLT3 inhibitors. In patients not candidate, consolidation chemotherapy has to be given. Regarding the prognostic impact of TKD, a recent meta-analysis has shown that these mutations do not affect the overall prognosis of AML patients. As mentioned before, MRD is a key prognostic factor in AML, and more and more is necessary to study this mutation by NGS because it is associated to high risk of relapse and reduce overall survival. And in patients with MRD, both quizartinib and gilteritinib have demonstrated that may improve the prognosis of these patients. The table is from the Quantum First trial and showing how the MRD positive patients do benefit from the addition of quizartinib. You can see here on the right the hazard ratio of protection from death, and also in a recent study also has been shown that gilteritinib improves post-transplant relapse in patients who are positive for MRD before or after the procedure. This is the seminal trial demonstrating that in patient in relapse, overall survival and event-free survival is superior with gilteritinib compared with salvage chemotherapy with high intensity or low intensity. This table summarizes the most important trials with FLT3 inhibitors. The first and the oldest one is the RATIFY in patients up to the age of 60, in which midostaurin was compared to placebo after induction, consolidation, and transplant, and showed a reduction in relapse and death. The same was observed in the Quantum First, but in this trial, interestingly, the patients were included in up to the age of 75, and quizartinib was also given after allogeneic transplantation, and showing again a benefit for patients with a FLT3 inhibitor. The third study is negative, the comparison of gilteritinib and plus AZA versus AZA alone. No benefit of the addition of gilteritinib. The VIALE-A showed the advantage of venetoclax or placebo versus AZA, and more recently are ongoing phase 3 treatment regimens also in patients with FLT3 ITD and FLT3 TKD. In the next ADS meeting, the triple combination with venetoclax, AZA, and gilteritinib was updated in patients with newly diagnosed AML. You can see in the table a 96% CR or CRI, which is an outstanding result, and by flow, a very good response on MRD, 93% and 65% by NGS. Below in the slide, you can see the 1, 2, and 3 year relapse-free survival in patients with FLT3 ITD receiving this combination, 64, 41, and 32%, and very good results in patients with TKD, 1 year, 100% survival, 2 years, 75 relapse-free survival, and 3 years, 75. And on the right of the table, you can see how RAS mutations, in addition to FLT3 ITD, confer adverse prognosis using this triple combination. Also in us was presented the Viceroy trial comparing venetoclax 200 versus venetoclax 400. And in this study, the main message is that the two possibilities, the two combinations, are effective and associated to good median overall survival, 23 months with 200, 22 months with 400. Also in ASH, it was presented a fully oral combination of the cytarabine, cedazuridine with venetoclax and gilteritinib with 80% of combined complete remissions, and the median number of cycles to best response was 1 month. In patients with relapsed disease, the outcome was not so good. At Hee-Je 225 was presented a phase 1/2 study of the cytarabine, venetoclax, and quizartinib in FLT3 mutated AML with FLT3 ITD, and this again in patients with newly diagnosed AML, combined complete remission of 94%, 61% negativity by PCR, and 58% by flow cytometry, and not so good results in patients with relapsed refractory AML. So in conclusion, the combination strategies with midostaurin, quizartinib, or gilteritinib have demonstrated beneficial survival outcome versus placebo in patients with newly diagnosed mutated AML. Triplet regimens combining FLT3 inhibitor, venetoclax, and AFA show promising efficacy in patients with newly diagnosed AML ineligible for intensive chemotherapy. Promising response rates also with the FLT3 inhibitor, the cytarabine, cedazuridine, and venetoclax, with the advantage of the oral route in patients with newly diagnosed or relapsed refractory AML. Gilteritinib monotherapy improved overall survival versus salvage chemotherapy in patients with refractory relapse AML, and personalized treatment approaches incorporating FLT3 inhibitors may represent a promising strategy for the treatment of FLT3 mutated AML. I have prepared as quite simple clinical situations in order that you interact and tell me what would be your preferred treatment option for this patient. This is a 60-year-old patient who is fit and has FLT3 ITD AML and concomitant MPN1 and DNMT3 mutations. And the possible responses are 7+3 plus midostaurin, clinical trial assessing 7+3 plus a menin inhibitor because there is concomitant MPN1, 7+3 plus quizartinib, or despite the age in that is fit, and taking into account the study presented as plenary in ASH, showing advantage of Benaza versus intensive chemotherapy, the last option would be Benaza plus gilteritinib. I would like to know some of your opinions.
On these patients, I would go with the today with the 7+3 plus quizartinib. We have good data with that combination. It looks very good. I think that the Ven/Aza gilteritinib deserves consideration just because there's emerging data of that combination. But I would probably go as my first choice with the 7+3 plus quizartinib. I wouldn't use a menin inhibitor instead of a FLT3 inhibitor in this situation. What the double combination would do, remains to be defined. But I wouldn't do a combination without a FLT3 at this point.
Yeah, I guess not many people would disagree with that. This is the triplet mutation, isn't it, that has been shown in Quantum First to do particularly well with quiz. You'd be wanting to take this patient to transplant. And you mentioned the Paradigm study, but of course they excluded patients with a FLT3 mutation, didn't they, from that study? So I think there are studies that are planned either using venasa-gilt or venasa-quiz compared with DA-quiz or DA-gilt in this patient population, Jorge, to precisely answer this question. But I suppose being rather reticent in the UK, we would be waiting for generation of randomized data to support that approach. I don't know if anybody else has got a different opinion on this.
I would just hi,
please.
Charlie. Hi,
Jeff, hey.
Yeah, no, I would agree with everything Jorge said, with the added stipulation that the randomized study of 7+3 plus quizartinib was more highly represented amongst patients that were older than the Ratify study. So I think that the patients were up to age 75, and I think a third of them were over age 65 in the study. So I think the fact that that patient population was better represented than in really any other study in terms of age makes me more of a proponent of the quiz approach, especially in the older fit patients.
Yeah. Any other comments, colleagues? Jorge, do you just have one case for us? Have you got more?
No. We move forward.
No, we move, right. Okay, that's good.
So is the same patient. The same patient, the patient achieves an MRD positive by flow cytometry and NGS, CR/CRi after induction and consolidation. Would now be your preferred treatment option for these patients? Change, so is MRD positive in morphological CR/CRi. So the option would be to change the FLT3 inhibitor, use as monotherapy with the aim of performing allo once MRD negativity is achieved. Second option, administer venasa plus a FLT3 inhibitor with the aim of achieving MRD negativity. C, to proceed directly to transplant with MAC or reduced intensity condition and administer post-transplant gilteritinib or quizartinib. D, if MPN1 MRD is positive and FLT3 ITD NGS is negative, administer a menin inhibitor.
Okay, great case. It goes on. I didn't know whether anybody would like to comment. I can see Dr. Walter is on the line. I'm always interested in what Roland has to say. Roland?
I think it sort of highlights one of the biggest uncertainties, right? Like it's fairly clear that the outcome isn't great, and it's sort of appealing to try to turn them to be MRD negative. It's sort of, you think that's good, but I think that the really convincing data that turns into something really beneficial is, in my mind, still a little lacking. So, and some of the studies that have tried to look at this, I think, concluded not much benefits. I think you could probably argue to proceed to a transplant and use gilteritinib, assuming for a minute the MRD is from the FLT3. It's a little more questionable what the benefit is if the MRD is not on the FLT3 side.
Thanks, Roland. I didn't know whether maybe Agnieszka or Gunnar had a different comment. Thoughts?
Yeah, so I don't have a different comment. So just based on the currently available data, so I would also proceed directly to stem cell transplant with gilteritinib post-transplant maintenance. And of course, it's still questionable the role of quizartinib as post-transplant maintenance, because the first analysis showed that in the Quantum First study, the patients who benefit the most from the quizartinib maintenance, they are the patients in non-transplant arm. And although if I recall correctly, only Richard Feng presented the data, but they are not published yet, regarding the quizartinib post-transplant maintenance and MRD. And also it was the suggestion that the patients with MRD positive disease may benefit for quiz maintenance. So from my point of view, there's still an open question regarding the selection of the optimal post-transplant maintenance with FLT3 inhibitors available. And still, in my opinion, the gilteritinib has the most convincing evidence regarding the FLT3 ITD disease, but so still think that this is the open question, and also like the medical need for the clinicians, how to select the optimal post-transplant
Thank you,
maintenance,
Agnieszka.
having
I think we agree.
and others.
Okay, next slide is the same patient, but who gets MRD status, MRD negative. What would be the option? Maintenance therapy with a FLT3 inhibitor, defer transplant until there is an increase in MRD or morphological relapse. Option B, proceed to allo transplant followed by treatment with a FLT3 inhibitor despite MRD negativity pre and post-transplant. Proceed to allo followed by treatment with a FLT3 inhibitor only if MRD becomes positive post-transplant. And D, autologous transplantation.
Okay, we're now blessed by, I can see Dr. Platzbecker. Hello, Uwe. I think you're on a phone. So
yes.
Uwe, your thoughts, and then maybe Dr. Kim's contributions as well. And then we've got one more case to discuss. Uwe.
Yeah, thank you, Charlie. I think this is something which should be discussed with the patient. As stated here, I think there are, to me, there are three options. I think auto transplant is not an option, at least not in my country. But I think I would be tempted if MRD can be tracked pretty well, and I have the opportunity to do maintenance therapy with a FLT3 inhibitor to actually go for the MRD triggered approach and actually delay transplant until the time of MRD is getting up. But of course, this needs to be discussed with the patient. There are patients who actually would like to go along those ways, and there are patients who don't. And therefore, I think that's important to have a conversation with the patient about that.
Right, thanks. Dr. Kim.
Okay. I'm sorry. In Korea, actually, any kind of the FLT3 inhibitors are available in Korea after transplantation. So, in practical point, transplantation should be the first choice, and that the only option for the relapsed refractory patient who receive the transplant is the sorafenib post-transplant is available in Korea, actually.
Okay, thanks, Dr. Kim. I guess from a UK perspective, we'd probably be thinking about taking this patient to transplant. Probably wouldn't be keen on using a post-transplant maintenance. There is some data, isn't there, in this patient population, younger patients, that the MRD negative patients may not, if OS is your primary endpoint, benefit from transplant. You're right, in those younger patients, it's a nuanced discussion, but that was also a data set that was quite challenging to interpret because the patients hadn't received a FLT3 inhibitor at diagnosis. So I think we would be inclined, if we had a good fit patient with a good donor, to say that the standard of care is as transplant still, and we're lacking evidence where we can confidently defer. Although I agree with you, Uwe, there are patients who may wish to take that approach, or in whom you don't have a great donor, or they're not so fit, in which MRD is helpful in making a decision not to transplant. So maybe the last question now, Jorge?
Yes. Okay, this is an old patient. 70 years old with comorbidities, with FLT3 ITD AML, and concomitant SF3B1 and IDH1 mutations. What would be your preferred initial approach for these patients? Venetha plus FLT3 inhibitor, ivosidenib AZA, or CPX351?
Okay, depends what you got available, I suppose. Maybe I'll pivot back to Dr. Cortes again. Jorge, what's your thoughts?
Well, I mean, the patient has the FLT3 ITD, and I think that the combinations with Ven-Aza plus the FLT3 inhibitors, these triple combinations, have been looking very, very good. So that would be probably my choice. Now, of course, it all depends on the setting, because if Ven-Aza is already myelosuppressive, the triple combinations are maybe more, and not every patient has easy access to transfusions and all that. So we always need to put that in the context of the setting where the patient is going to be managed. But I guess in most of our places we would have that option. So that would be probably my
great
preference.
Jeff, maybe some final thoughts, comments from you.
Next.
Yeah, as much as I would like to consider CPX. No, I'm just kidding. Yeah, I agree. I think we know that the doublet combination with Ven-Aza in ITD is not particularly effective in the short or the long term, and the combination triplet strategy looks to be most appealing for long-term benefits. So I would favor that with a careful eye on toxicity, because it is more myelosuppressive. I think the Ivo-Aza, although it's less toxic, is not likely to be very helpful in this patient, just based on the knowledge that these patients with IDH and other, RAS activating pathways don't do very well with IDH inhibitors. So I would favor the triple.
Thanks, Jeff. So no CPX for this patient. Tough. So perhaps last comments then, Jorge.
Well, I had more cases, but
you have
but it is late already. So is the patient is the same patient that after 4 months in CR has MRD positivity. What would you do next? Continue the initial therapy, change the approach from Ven-Aza backbone to ivosidenib AZA or vice versa, assess ECOG performance status and comorbidities, and if adequate, administer CPX if not used previously, or assess ECOG PS and comorbidities, and if adequate, proceed to allotransplant followed by gilteritinib or quizartinib.
So maybe I could just turn it. Is Dr. Miyazaki with us? It's a really complicated question, but Dr. Miyazaki,
yes,
would you like to comment?
It is very difficult, because 70 years old has a very wide variety of their conditions. So although it looks like fit for transplant, but once we do even a reduced conditioning, their general condition deteriorates easily. So I prefer to continue the initial therapy as long as MRD level FLT3 positivity cells remains.
I don't know if anybody strongly disagrees with that. It's probably the only approach. Thank you so much. Jorge, that was outstanding. Have you got any closing remarks for us?
Well, I think that the prognosis of patients with AML and FLT3 mutations has clearly improved with the introduction of the TKI inhibitors. This has been demonstrated in patients fit for intensive chemotherapy, and the results are promising in patients not non-fit for intensive therapy, but randomized trials are needed, demonstrating that the triple combination is superior to the combination of Ven-Aza.
That's great. That was a most illuminating series of presentations. Good discussion. So thank you, everybody.
Charlie, I have a very quick question.
Yes.
In Japan, midostaurin is not available yet.
Okay.
But in your country, probably quizartinib and midostaurin are available, right? So why there is no opinion regarding the midostaurin?
Yeah, maybe just leave Jorge to kind of leave some comments. Mido versus quiz. Jorge, what's your advice?
Well, the benefit in terms of survival seems comparable. So basically, I would take a decision based on the potential toxicities of each of the two inhibitors. So this would be basically the decision. In practice, probably I would not recommend midostaurin in patients above 60 years, and I would be prone to use quizartinib in patients above this age, because you have more data. But basically, it would be a decision based on the potential toxicities.
Yeah, that's important. I think the other observation is in the Ratify study, as I read it, the survival benefit was in the transplanted patients, but not in the non-transplanted patients. Whereas with quizartinib, there is a benefit in both transplanted and non-transplanted patients. And that actually, since you don't know whether a patient's going to go to transplant, pushes many people towards quizartinib, providing the patient can tolerate it, and tolerability is a key consideration.